Our last speaker for this morning is Professor Asim Al-Fadda. Professor Asim is an senior consultant of endocrinology and internal medicine at King Khalid University. Professor Asim, we know him that he's a leader in the field of obesity, and the his efforts in tackling obesity in this country is well appreciated. Professor Asim, he got his degree in medicine in King Saud University, and he got his internal medicine and endocrinology training in McGill University, Canada. Also, he got physiology, a degree in physiology and obesity at McGill, and he got an MBA in the International Healthcare Management, Frankfurt School of Finance and Management. He will talk about obesity and osteoarthritis. Awesome.
Assalamu alaikum wa barakatuh. Alhamdulillah wa salatu wa rasulullah. Thank you for the organizing committee for inviting me to talk to you today about an important complication of obesity, which is the osteoarthritis, and specifically knee osteoarthritis. With the wide range of complications of obesity, we don't need to forget that our knees are very important in many aspects of our life. And I hope by the end of this talk, I could convince you that we could do something very important to our patients who are suffering from obesity and overweight in terms of helping them in reducing the pain they are having and to improve their lifestyle. So these are my disclosures. I'm going to talk to you today about different aspects in osteoarthritis, specifically in the knee, and the pathophysiology, epidemiology, diagnosis, and treatment, and finally ending by presenting the data from STEP 9 study, studying semaglutide in the effect of knee osteoarthritis. So definition of osteoarthritis is very clear of the knee. It is a degenerative joint disease that will lead to the progressive loss of the cartilage in the knee, and this will cause, of course, pain. And early morning stiffness is not that typical feature of knee osteoarthritis. Usually, it could be less than 30 minutes. And, of course, OA of the knee will have functional limitations. And this specific risk factors are related to the age and some genetic factors. Obesity and females are more prone to have knee osteoarthritis compared to males. And also the trauma or the poor muscle function, muscle weakness, and also meniscal injuries considered to be risk factors for knee osteoarthritis. The widespread of this problem is all over the world, and you can see that the global prevalence of OA, depending on the age group studied, is about 16% if you study patients or people more than 15 years of age, or about 23% if you are talking about people more than 40 years of age. And the prevalence of osteoarthritis of the knee is also, the incidence would also increase significantly between the age of 50 and 75, more in females. So this is the typical increment and the incidence of this problem. The association between obesity and knee osteoarthritis is very well known, and in different studies, whether we are talking about case control or cohort studies, the odds ratio will increase in patients with obesity. And in this excellent study, you can see that patients with overweight and obesity were approximately 2.5 to 4.6 times more likely to have knee osteoarthritis than patients with normal weight. The burden also of this problem is not only for patients, also it's for economy. And this study summarized the 8-year cumulative direct healthcare cost per person living with obesity and knee osteoarthritis. And the more severe the obesity is, the more or the highest cost that we are spending to treat this problem. So why do we develop knee osteoarthritis in patients with obesity? Of course, the mechanical causes are there, and we know that with pressure on the knee, this will cause progressive tear and damage to the cartilage. But also we should not forget the inflammatory cascade that is going on in the knee itself, starting with the adipokines and the inflammatory cytokines with progressive inflammation. And the inflammation in patients with obesity, as we all know, is a chronic state of inflammation, systematic inflammation, and specifically in the knee with the repetitive pressure and active inflammation, the problem will be even worse. So it's a combination of mechanical factors plus inflammatory metabolic factors that would cause this disease to progress with time. So in terms of diagnostic criteria, we know that the patient will have a pain, and this could be associated with either clinical findings of being more older than 50 years of age, with a short period of morning stiffness, crepitus, bony tenderness, and bone enlargement. There should be usually no palpable warmth or of the synovium. Patient also with pain could have radiological findings of knee osteoarthritis plus some of the clinical findings. The classification of the degree of this disease is being studied by this Kellgren-Lawrence scale, and the progressive of this disease is based on the problem in the joint itself, starting with the minimal disruption to space narrowing to a joint space reduction and gap in the cartilage itself, and then to the severe stage of large joint space reduction with cartilage loss and large osteophytes. Just make sure that you remember this when we talk about the STEP 9, because in the STEP 9 studies, patients were enrolled if they have class 2 and class 3 osteoarthritis. How to assess also the problem of this disease. This is the Western Ontario McMaster University classification of osteoarthritis. Called the WOMAC scale, including pain, stiffness, and physical function. This scale is between 0 and 100. The higher the scale, the higher the problem, and the worse is the outcome for the patient. So what are the treatment options we have? Different associations discuss this, and this is a summary of the American College of Rheumatology saying that the strong recommended things is to have weight loss, exercise, and also using anti-inflammatories that, of course, need to be considered not to cause any problem with the GI tract, but also local injections with steroids could be considered. The weight reduction has been recommended by almost all associations in patients with obesity, so it's strongly recommended to reduce body weight to improve the knee osteoarthritis in patients with overweight and obesity. So what are the benefits of weight loss in patients with obesity and knee osteoarthritis? Different studies discuss this, and the majority on this study, for example, achieved 10% or more weight loss. 64% of patients experience significant symptomatic improvement in their knee osteoarthritis. So the more the weight loss, the better the symptom relief in patients with knee OA. This study also showed significant finding of weight loss being a significant factor to reduce the need of knee replacement. So weight reduction of 2 kilograms will decrease the percentage of the need of knee replacement by about 10.9 percentage. The more weight, 23.6, and achieving normal BMI would decrease the need of knee replacement by about 57%. And also this important study from China using whatever type of GLP-1 we have, you can see that we have significant improvement in the WOMAC pain subscale in the third figure there. You can see that the WOMAC itself, the total scale, is been increasing in both GLP-1 and non-GLP-1 users, but this will tell us that this is a progressive disease. So whatever we do, it might progress. What we are trying to do is to decrease this progression. And you can see in the last figure on the right side there that using GLP-1 significantly reduced the need of surgery or knee replacement in these patients. So in the last part of my study, I'm going to talk about the STEP 9 study, which is a landmark study studying the effect of semaglutide 2.4 milligram in people with obesity and knee osteoarthritis. This is an international study in different centers in Saudi Arabia. We had the privilege to have 4 centers participating in this study. So the study objective was to confirm the superiority of once-weekly semaglutide 2.4 milligram versus placebo as an adjunct to a reduced calorie with diet and increased physical activity in participants with obesity and knee osteoarthritis. And this is compared to their baseline status. So it included 407 patients, more than 18 years of age, with obesity, BMI 30 or more, a clinical diagnosis of knee osteoarthritis with moderate radiograph changes. As we remember in the last slide, the KL grade 2 and 3, they should have pain due to knee osteoarthritis and a score of 40 or more in the WOMAC pain score. Randomized to semaglutide 2.4 milligram with lifestyle intervention versus placebo plus lifestyle intervention, and followed for 68 weeks on the treatment and then to week 75 of treatment. So the key study endpoints would be the change in the WOMAC pain score and the change in the body weight. The confirmatory secondary endpoint would be a proportion of participants with a body weight reduction of 5 or 10%, change in the WOMAC physical activity, change in the physical function score, and the supportive secondary endpoint was waist circumference, WOMAC stiffness score, WOMAC total score, pain intensity measurement, and use of pain medications. This study had a very rigorous sort of pain assessment. Patients who were included in the study were asked to measure their pain daily in a daily diary, and also before each visit they should have a pain medication washout period of 72 hours to make sure that this will not affect the WOMAC scale measurement. So with 785 patients screened, ended up by having in the placebo arm 122 patients and 246 patients in the intervention arm. These are the demographics. You can see most were females. As we discussed before, females are more prone to have knee osteoarthritis. 56 years were the main age, and the main BMI was 40.3 kg per meter square. These are the major comorbidities: hypertension, dyslipidemia, cardiovascular disease, and obstructive sleep apnea. So as we expect, the expected treatment difference between the two groups after following up for 68 weeks was about 10.5%. This is replicated by almost all the STEP studies. And significant improvement was observed in the WOMAC pain score, and you can see that the ETD was 14.1. And remember that we are talking about a scale between 0 and 100. The mean score in this patient when they started was 70. So from 70 going down to minus 41.7 would be a significant improvement in the WOMAC pain. And this, I think, is the most important, most interesting slide for me in this study. As you can see that the left is semaglutide arm, the right is the placebo, and you can see the types of analgesics they are using, whether it's opioids, non-steroidal anti-inflammatory, or acetaminophen. You can see that this clear trend in the use of or analgesics medications in the semaglutide compared to the higher trend, almost stable trend in the placebo group. So not only improving the pain, but also improving the dependence of these patients on analgesics to improve their knee pain and function. As we expect as well, the change from baseline WOMAC in the physical function, they have better function. The reduction was significant in this scale. So more reduction in this scale, the more they're becoming more and the safety side effects is really not that different from most of the STEP programs, mainly stopping the medication related to the GI side effects as we expect. And also the other side effects profile were almost similar to other studies in this STEP, and no significant or red flags has been discovered in this trial. So I hope by this I could convince you that knee osteoarthritis is a very important factor in our patients with obesity. It should be diagnosed, managed, as soon as we can to prevent the progression of this disease, to prevent the patient loss of lifestyle or loss of physical function, to reduce the risk of the knee replacement and the need of knee replacement. Right now, we do have strong evidence that also interaction or intervention with GLP-1 receptor agonist, specifically semaglutide, would improve the outcome in these patients. It will have improvement in the reduction of the body weight. It would have an improvement in the physical function of these patients. It will improve their pain score. It is a safe medication to use. And the result of this study would really be in favor of using semaglutide 2.4 as a weight management tool in treatment of patients with knee osteoarthritis and obesity. Thank you very much.